emergency medicine, FRCEM inspired revision notes. In particular, this is while I've been revising for the FRCEM SBAs and will be helpful to others, but also for clinical practice. Set to deep focus music to help fact retention. We will start with advanced life support. These are commonly tested both in FRCEM, MRCEM, OSCEs and SBAs. We're going by the 2025 guidelines. With an unresponsive patient with abnormal breathing, call the resus team. Remember, CPR is 30 to 2. Attach a defibrillator early and assess the rhythm. If a shockable rhythm is found, you move straight to the shockable arm of the algorithm, administer a shock, and resume CPR for 2 minutes at a rate of 30 to 2. Shockable rhythms include VF and pulseless VT, and we should be able to recognize these for the exam and for clinical purposes. If it's a non-shockable rhythm, which would be asystole on the monitor, or PEA, pulseless electrical activity, where there's no pulse, then you give adrenaline immediately every 3 to 5, and then every 3 to 5 minutes, resuming CPR for another 2 minutes. And every 2 minutes, you are reassessing the rhythm. While each cycle of CPR is ongoing, you are assessing for the reversible causes, the 4 H's and the 4 T's. 4 H's being hypoxia, hypovolemia, hyperkalemia, calcemia, magnesium, hypoglycemia, hyperthermia, and the 4 T's, thrombosis, coronary or pulmonary, tension pneumothorax, toxins, and tamponade. High quality chest compressions and ventilations, ensuring optimal defibrillator pad placement, giving oxygen, using continuous compressions of tracheal tube, using waveform capnography, minimizing interruption to compressions, early IV access, IO if IV not possible. On the shockable arm of the algorithm, remember you only give the first adrenaline after 3 shocks, and then every 3 to 5 minutes. Consider using a Lucas device for mechanical chest compressions to increase efficiency. Using ultrasound to identify reversible causes, particularly tamponade, tension pneumothorax, as well as assessing the heart. But remember the guidelines not to delay compressions or shocks for any of that. Here we can see on the screen, as we're following, the algorithms themselves. Here are the various drugs used in the advanced life support algorithm with their doses. So we've got adrenaline, 1 mg IV IO after 3rd shock on the shockable arm, repeating every 3 to 5 minutes, and 1 mg IV IO as soon as possible on the non-shockable arm, then repeating every 3 to 5 minutes. Amiodarone 300 mg IV IO after the 3rd shock, and then 150 mg IV IO after the 5th shock. Atropine 0.5 to 1 mg IV up to 3 mg if a reduced vagal tone is a likely cause. With the reversible causes, if we identify hyperkalemia, we would be giving calcium chloride 10 ml of 10%. We'd also give this in the case of hypocalcemia. In hypokalemia, we'd be giving potassium 20 millimoles IV over 10 minutes, and then 10 millimoles IV over 5 to 10 minutes. If we see polymorphic VT, where there's hypomagnesemia, 2 grams IV magnesium sulfate, you'd be giving 4 grams IV in the context of eclampsia. This all depends on the clinical history. Again, none of this is delaying the core ALS cycles. Alteplase in the instance of suspected pulmonary embolism, which we will talk about in a specific section On special circumstances, a 50 mg IV bolus, an intralipid if we're suspecting local anesthetic toxicity. And with refractory VF, we would consider, or refractory shockable rhythms, would consider AP or biaxillary pad positions. The pads must be more than 8 cm from an ICD. We'd normally start with anterolateral pad positions. Single shocks as default, with 3 stacked shocks only for witnessed monitored cardiac arrests. Remember, once we do insert the supraglottic airway device, IGL or LMA, it's continuous compressions. And as we said earlier, capnography is mandatory and should be visualized throughout resuscitation. A rising PCO2 can suggest RUSC, delivering 10 breaths per minute, each over a second.